For pregnancy and lactation professionals and parents-to-be, the First Exposure podcast offers safety information and clinical guidance about medications, drugs, and environmental exposures. Join us at firstexposure.ca.
Welcome back to the First Exposure podcast. I'm Dr. Tali Bogler. In part 2 of our episode on cannabis use during pregnancy and lactation, we're going to continue our conversation with Dr. Oyedeji Ayonrinde and Dr. Suzanne Turner. And we're going to explore the latest evidence, disclosure challenges, and motivations for using cannabis in pregnancy and lactation. So let's jump right back in. If you have somebody that comes to you, they're newly pregnant and they want to cut back, or they ask, well, maybe is a gummy safer than vaping or smoking? I'm speaking in terms of harm reduction. What are some of the advice that you would give someone in terms of how much to cut back, or if they're asking about different forms could be considered safer than others? What would you advise? And if somebody wants to cut back altogether, are there other substitutes that you could give that could be safer in pregnancy?
Sure, happy to discuss that. So we kind of go back, I always base it kind of on our 3 longitudinal studies. So we know that having the lowest THC component product possible is going to be your safest bet. So if someone is saying to me, look, I'm going to use THC, so I'm going to use cannabis regardless of what you tell me, but how can I do it safely? I basically say, okay, so do you know what percentage C you're using right now? Try and get a sense of what their route is. So if they're, let's say they're smoking joints, I basically say, first of all, can you buy from, a store as opposed to a non-prescribed source, so that we can have a little bit better understanding on the packaging of what percentage THC you're using. And then we can slowly try and titrate that down. The other component of it is frequency, so how often you're using it. So again, this comes back to, we know that limiting your exposure to THC, both the percentage and the frequency, is going to lower those risks associated both with birth weight and length, but also the potential longitudinal effects associated with the neonate and the child. So can you try, rather than using 3 times a day, can we try and go down to twice a day? After you do that for a bit, can we try and go down to once a day? So there's a couple of other considerations. I very much try and have people avoid using edibles for a variety of reasons. First of all, if there's other children in the home, we know that edibles are associated with a dramatic, catastrophic increase in THC toxicity emergency room visits for children. So really having edibles that look like gummy bears, oils, cookies, brownies, any of those things, they're very attractive to children. And those of us who have kids all know that it's almost impossible to keep kids out of places that they're not supposed to be. And so if we can avoid edibles, that would be really, really ideal. The other thing is that vaping THC is associated with a constellation of other health problems. So there's been documented lung injury associated with vaping THC containing products, probably related to some of the fillers that they use to vape it appropriately, depending on what kind of vape product you're using. And they're constantly changing, so it's difficult, but sort of saying to them, try to avoid that. And then the other thing, so Deji talked about shatter, that's like very, very high potency. That would be like, okay, we got to quickly figure out how we can reduce that potency. But also the thing I worry about is people using poppers. So basically using a combination of tobacco and cannabis together, usually through a bong. We know that patients tend to breath hold and take deeper breaths when they're using the combination together, which leads to much higher levels of THC going across the blood-brain barrier, but also likely across the placenta. So trying to get them to separate out their tobacco and their cannabis can be another strategy. I think what we're seeing as I'm like trying to go through all of these pathways is part of the issue is you have to know what your patient's using and how they're using it. And there are so many different products available, it becomes very, very challenging.
And I would even back up one step further.
Yeah.
It's actually even getting our patients to disclose this, or for people to even feel comfortable to tell their provider. So, that's something I often think about. If people know this isn't safe, why are they going to bring it up to their maternity care provider? What are they going to say? How are they going to judge? And it's also about creating that safer space, or how do we ask in a better way so that people feel comfortable disclosing what they're using at home.
I mean, Tali, I think you make a really, really good point. So there was a study in 2017 that was sort of revolutionary to the obstetrical population, which, I mean, it's almost 10 years old now, but I think it's still compelling, where in California, in a very large HMO, they basically looked at the pregnancy population coming through Kaiser, and they asked them if they were using THC. And then they also, patients with informed consent, provided a urine drug screen, and they looked at what the correlation was between those disclosing that they used cannabis and those that had evidence on their urine drug screen. And it was almost double on urine drug screen. So first of all, we know that patients aren't disclosing. But the other concerning factor, and again, this is almost 10 years old now, so it's probably much higher rates. But again, in the less than 18 population and those between 18 and I can't remember if it was 24 or 25, it was almost 25% of pregnant people, again, in a very large population study, were using THC containing products. So again, we know that this is super common. And so what I say to patients, if I'm not in my substance use program, which is a bit different, but in a general, as an obstetrical care provider, basically say, look, THC cannabis is super common. I even say it to them. I say, I expect about 25% of my population are using cannabis containing products. These are the reasons I'm asking this question. Could you tell me, have you used cannabis recently? If you decide you want to use cannabis in the future of the pregnancy, can you let me know so I can provide you some information? And so it's sort of kind of normalizing it, like saying, hey, like, this is super common. Is it okay for me to provide you some information about cannabis in pregnancy and some of the reasons that as your care provider, I'm a bit concerned, and how we can move you to a step that might be a little bit safer for the pregnancy moving forward? That's my general approach.
Yeah, I like that a lot. Yeah.
I think that the problem is, for those who are listening who are obstetrical care providers, we know it's like a tick box on the Ontario prenatal record, right? So it's like this tiny tick box at the bottom of a very long set of tick boxes. And it takes a lot of time and effort. But again, it's so common. It probably behooves us to try and, at least normalize it a little bit so that we can get some more information.
And a lot of the time, patients are actually filling out these forms themselves now. It's not even a healthcare provider even asking the question. And so what would make somebody, Deji, if you were to encourage somebody to disclose this information, how would you sort of encourage someone to want to disclose this?
Yeah, well, I totally agree with Suzanne. I aim to reduce the stigma around it and by no means come across as judgmental. People, on the whole, aren't using cannabis with the objective to harm their unborn child. And if we as health professionals make people feel stigmatized, unsafe, judged, then it'll be a lot more difficult to disclose. And so one thing I avoid framing a question is, do you smoke? I do ask it in a much broader sense, because you could ask someone, do you smoke cannabis? Oh, no, goodness, no, I don't smoke. But they may have consumed edibles or any other roots. And it's not uncommon. Some people actually do use cannabis products even before a consult, just to relax themselves. So it's important to normalize the conversation, not to judge. I like Suzanne's approach of putting out a statistic that it's quite common, so you're not going to be a stand-alone person. I encourage people to bring their products in a Ziploc bag or something. Just bring it. Let's have a look at the packaging. And we talk about the packaging. And with the best of intent and knowledge, so many people misread their packaging. They read things like THC and total THC without being able to know the difference. And THC may read 3%, and then total THC may read 80 something, or THC may read 3 milligrams, and total THC 80 something. And when you ask people, what does that mean? So I thought that was what the whole package was, and then if I took a little bit, it'll be that. But no. And sometimes the way we explain can help people, okay, so your THC is like a car just parked in the driveway or just moving in very heavy traffic. And then total THC is the maximum amount of THC you can get out of that car. On a motorway, free of track if you put your foot down on the gas. And it's, oh my God, I didn't know. I thought I was using a low potency product. Helping people better understand the packaging and labeling, destigmatizing, and the information we make available regarding lower risk and lower harm guidelines and guidance, not being, um, a message that suggests if anyone's with their partner or their couple, to allow the discretion, because it could go really badly wrong. The person may not disclose because there's another person around, a parent, a partner, an in-law, a sibling, and they might be their little dark secrets. So some of those sensitivities.
And I think you make a really good point, Doji, if I can build on that. So we talked at a question or two ago about, most people know that alcohol is harmful in pregnancy. And I would say that we haven't had the same kind of public health kind of exposure to messaging that probably exists for alcohol. Also for cigarettes, I would say that, there's good kind of packaging and that kind of thing. And so I think that you're right that we have to be careful about how we provide the information because, in my line of work, I have people who won't disclose that they've used alcohol. And there's actually lots of things that I can do to help them if they're having difficulty with alcohol in pregnancy. But because the messaging is so black and white, many people are very hesitant to disclose. And that's one of my concerns moving forward is we really need to get the information out about the potential harms, but we need to do it in a way that people feel really comfortable in disclosing. And that's a very, very fine balance. But I think, we are really at risk of losing people and having them continue that like little dark secret that's really potentially causing them distress. And how can we balance that moving forward? Because I think it's a good point. Most people know that alcohol is harmful in pregnancy. We don't have the same kind of signage, messages kind of constantly bring us about THC, but we also want people to be able to disclose. So it's that constant kind of fine balance between it.
Yeah. Just speaking to that a little bit, if somebody does disclose and they want to stop, what are some treatment options in pregnancy, Suzanne?
We don't have great treatment options compared to other substances. So opiates, we have a really clear understanding of how to treat a opiate use disorder. So the first thing would be kind of asking the patient, have they ever tried to stop before? What did that look like? What were some of the things that became difficult? Sleep can be a real issue. Being able to eat can be a real issue. So trying to look at impaired their ability to stop previously, and can we kind of come up with a strategy that may help with that? Outside of pregnancy, there's, some limited evidence for N-acetylcysteine for managing the immediate kind of withdrawal to 12 weeks out after stopping in terms of making it more successful. We don't have any safety data on N-acetylcysteine in pregnancy. So that's why I'm saying kind of prior to pregnancy. And then other medications can be helpful. I've seen people become suicidal, highly anxious, repeated panic attacks, if they stop abruptly. And so sometimes what I'll say to them is, can we figure out a tapering strategy? That would probably the one I use the most. So again, that's where Deji's idea of bringing in the packaging so we can look at it together, having an idea of how you're using it, what would be an appropriate way to help you try and taper. My rule of thumb is very similar to other psychoactive compounds, which is trying to reduce your total exposure by 10% per week. So if you're using like a gram of cannabis bud and you're smoking joints, trying to go down, to 900 milligrams for a week, and then slowly taper it and using a kitchen scale to actually weigh it. And using the same THC content. So not to say that this is easy at all, but certainly giving patients hope that there is ways to taper and stop, and that we have medications that can be effective in terms of managing those side effects of trying to stop as well.
Yeah. And as you said, really focusing on the pre-pregnancy period is ideal. Having, when couples or somebody's trying to conceive, having those discussions early, right? So talking about recreational substances and what people are using at home prior to conceiving. And just to add to that, and I know it's a little bit, Deji, you wanted to say something. I wanted to ask one more question about the preconception period. Deji, you wanted to add. Sorry about that.
No, that's okay. Just adding to what Suzanne said, also in the tapering off, and one analogy I sometimes give people is it's like you're trying to land an aeroplane, and it's a gentle process. And during that period, there may be a bit of turbulence, but the goal is to land. And helping familiarize people with cannabis withdrawal syndrome symptoms. So there might be an increase in nausea, have disturbed sleep or mood changes. They may feel a bit more anxious and so on. And it may go on, with the first week more than the second week. But being realistic with them in such a way that those experiences are things they expect. And as they're putting on their seatbelt to land, supporting them through the process. It can be tricky and it's not easy, but overall, there are ways we can help people appreciate the science that they will see the logic themselves and know what to expect.
I can imagine having those withdrawal symptoms are particularly tricky when pregnant, right? Because it's often that you might feel nauseous in pregnancy, especially in the first trimester if somebody's just found out they're pregnant and trying to cut back on their cannabis use right away. So that's it can be tricky. And I think being honest about that and saying, up front, as you said, there might be some turbulence, but we're going to land, is a really nice way of framing it.
Well, the only thing I was going to mention was we talked a little bit about partners and other people involved. So we know from the substance use literature, which not all people are going to have a substance use disorder, but I think it's helpful to kind of use that literature. And it's also from our smoking literature, that it's much more effective if it's done as a dyad. So if, the partner is also using cannabis, trying to come up with a strategy, inviting the pregnant person to invite their partner in, is that something safe for us to discuss about how, you both can stop? Because it's certainly going to be much more challenging if, the partner is also using cannabis kind of at the same level and smoking a joint right next to you. That's not going to be an easy process. And so really trying to look at it as like a family event can sometimes be really helpful. And some people will say to me, this was like our first test as parents, right? We kind of had to come together and figure out a strategy. And it can be a process that helps bring the couple closer together if that's something that's helpful and safe for the partners. So kind of talking about that as well as, reasons to look at this as a family, but also in the pregnancy and the pre-pregnancy period. So that we're not dealing with this immediately after baby is born when everyone's sleep deprived and exhausted.
I'm going to add to what Suzanne said, which is a great and a very visual example as well, because the relationship may have been consolidated, let's say, after a long day at work, and both are smoking, if they smoke, using cannabis together, watching a movie or something. And even if the pregnant person chooses to stop using, if the partner's next to them and there's that much active passive smoking, they are inhaling. And if it's a nice long movie with a lot of smoke, they're getting a fair bit of cannabis in. So if the partner isn't going to support with abstinence or not using, perhaps they can go outdoors or, somewhere that'll be safer so that the pregnant person isn't as exposed to smoke as possible.
Speaking about the partner, in the fertility world, so preconception, you hear a lot of people counseling on the partner sperm, cannabis having an impact potentially on fertility, quantity and quality sperm. Do either of you know much about those studies, and what do you counsel your patients on about that? Suzanne, do you know? Deji? Either one.
Well, let's put this way. If we imagine spermatozoa, that's a long medical name, but sperm like little tadpoles, and millions on a journey seeking to achieve a pregnancy. Now, there's increasing evidence that exposed to cannabis, predominantly to high THC type of cannabis products, the spermatozoa do not maintain that purposeful movement. So it's pretty much like moving around in circles, going backwards, sideways, and so on. And this is worth seeing under a microscope. The sight of spermatozoa exposed to THC is something no man would ever.
It is pretty impressive, I agree.
It's something. So, for pregnancy, it takes a couple, whether partnered or not. I think recognizing that it's the couple's pregnancy, or in some situations, but it's a shared responsibility, and the partner can do their bit in that sort of context. As time goes on, we're going to have in more and more genetic information on what it's like even for the sperm to be exposed. What's that doing to the coding? And are there specific epigenetic type, as in environment versus the genes, interactions going on? There's a lot we don't know.
I think one of the things that this also ties into, it's really related to the THC impacting what's called the HPA axis, the hypothalamic pituitary axis, and it is a cascade of hormones that really kind of probably impacts the sperm production. And there's been some studies that have shown this mostly in animals, but we also have the studies that Dre mentioned in humans, looking at the quality quantity of sperm produced when there's high THC exposure. It maybe segues into a good discussion about lactation, because there's also some early evidence that same pathway in the lactating individual may be impacted, because prolactin can be negatively impacted by high dose THC. And so it's the same pathway, just different sides of it, that's really kind of impacting kind of multiple components on this pregnancy journey.
And just to emphasize that or clarify, Suzanne, what you mean then is that if prolactin is lower, potentially someone's milk supply could be impacted by using THC. And just backing up again, when you talk about the HPA axis, I know we're talking about endocrine kind of things, does using cannabis quite frequently impact the female's reproductive organs in terms of ovulation or fertility? Do we have any studies on that?
We don't really have good quality studies. So the studies that are most compelling are those on spermatozoa production and lactation. So those are the two mainly studied areas. I mean, it would make sense that it's impacted. I just don't think that we, from a physiological standpoint, just given the inputs on where THC is impacting the pathway, but we don't have compelling studies right now.
I was actually going to ask, because I think people are like, well, if I just use marijuana once and then like in 2 weeks from now try to conceive, should I be concerned, right? Like, how close in timing does use become an issue in terms of it impacting the sperm? Are we talking about like that sperm that you were seeing under the microscope? Did the person just use THC, or is that something that over time would have an impact on the sperm? Can somebody answer that? Because I think that would be helpful for partners to know.
Okay, so in terms of sperm production, I think the important thing to know is that, it takes sort of 3 months. It's on a 3-month cycle that sperm are produced. And so THC exposure is complex. So if you are a chronic THC user, then you can have THC in your fat stores for up to 30 days. So it can take 30 days after your last use for THC to no longer be in your system, which would mean that you would need sort of 3 months before you may see the effects of THC no longer present on your sperm. If you're an intermittent user, it really would depend. It kind of depends on frequency and potency of the THC, but certainly knowing that the sperm have a 3-month kind of life cycle is really important. So not sort of stopping is not going to lead to improvement in your sperm quality necessarily tomorrow or the day after.
I think this, although a very different topic, but in terms of THC sticking around in the fat, can we talk about lactation a little bit and breast milk? So, very much in the media right now, I'm seeing a lot of like, the terminology canna moms or weed moms, and this sort of movement in the postpartum period to use cannabis here and there, sort of like alcohol, and just sort of the acceptance around that, or this movement around that. And I'm curious from both of you sort of to speak on that. And then more specifically, what should we know about THC in someone who is breastfeeding? And what do we see in terms of THC in the actual breast milk? Suzanne, I'm going to get you to start with what we know about breast milk specifically, and then maybe perhaps the broader cultural change.
So THC in lactation is quite complicated. So I think there's a couple of kind of main principles we need to remember when we're talking about THC exposure. So the first is that THC is very lipophilic, which means that it really likes fat. And so it concentrates in fatty areas, both in the adult body, but also in things like breast milk, which is extremely fatty. And then there's some concern, although we don't have great studies to look at this, babies are predominantly fatty creatures. So they have a high proponent of fat, which is obviously protective in the neonatal period. So there's some studies from the East that looked at concentration of THC in breast milk. Particularly of concern was showing that serum levels, so the amount of THC in the lactating individual's blood, was significantly lower than the THC content collected at the same time in the breast milk. And so the concern is that even though we don't feel intoxicated if we've used THC recently, that the amount of THC that the neonate may receive from ingesting that breast milk may be significantly higher, like 5 to 8% higher than what is in the lactating person's serum. So that's a first concern. The second thing is that, as we sort of previously mentioned, THC stays in the system for a long period of time. So if you are a chronic THC consumer, meaning that you're using daily or near daily, which is every other day to 3 times a week, it can take up to 30 days for the THC to come out of your fat stores. And so we're not very good at modeling what that looks like. So how much is released, how quickly it's released when you're abstinent. And then we don't have good data on what that percentage in the breast milk would be during that abstinent period where you have, the 30 days where it's being released in that process. So that's the other thing to consider. And then some of the studies that people will talk about in the media to support this really kind of looked at THC exposures that were one time. So I'm thinking of one of the Hale studies where they basically looked at a small number of lactating women that had a very broad kind of exposure period. So, some of them were relatively new postpartum, some were like 6+ months out. So a lot of differences in terms of the quantity and components of the breast milk that were being produced. And so in a lab environment, had people consume like a smoked THC product and then looked at the THC components over time. The main concern in that kind of study is that those people were largely abstinent before, so they didn't have kind of a baseline THC in the body. So that's the first thing. And then the second thing is that even after that kind of initial one-time exposure, it can take days for the THC to actually stick around in the breast milk. So we've got like many, many days where the neonate is still getting THC exposure from a one-time event. So there's kind of 2 components. Those 3 longitudinal studies I mentioned before also had neonates that were exposed to THC. So they're kind of in that kind of larger conglomerate of data that basically says that we think that there's a dose-dependent effect. So the more exposure that you have, the higher the risk of neurodevelopmental outcomes on the offspring children. But we're able to sort of tease out kind of pregnancy-related exposures versus lactation-related exposures. But again, kind of remembering that we've mentioned before that the THC content in products currently is significantly higher than it was. So if we go back to the 90s, we're talking like 1 or 2%, up to maybe 4% being a high potency THC containing product versus 80 to 90% now versus kind of the baseline that's in the 20s. So we know that there's lots of concern about kind of chronic THC exposure and then the impact on lactating. So one, it may be more difficult to lactate because of the impact of THC on the HPA axis and maybe not producing as much prolactin. For those who are lactating, kind of the concern about concentration of THC in the breast milk. And then thirdly is kind of this long-term exposure associated with neurodevelopmental outcomes in THC.
Yeah, great. Thank you so much, Suzanne. And just, I know most of our followers at this point would understand this or already know this, but just how much the brain, it doesn't stop developing in pregnancy, right? It's rapidly developing in the neonatal, infant, child period, and how vulnerable the brain is even once the baby's delivered. And I think most people know that, but I think it's important to just highlight again. Deji, what do you want to say or comment on this discussion, specifically about the culture around, here or there some cannabis while parenting and sort of the acceptance or the discussion around that at the moment?
We need to be thoughtful about culture because a lot of culture in contemporary times is fed by media, social media, different platforms, people saying something's cool or trying to generate fads. There's information, there's misinformation, which is a mistake type of information, and there's disinformation, very deliberate attempts to mislead or to cause harm with information. And I would strongly caution that people who are tempted or seduced or choosing to experiment with some of these fads seek reliable sources of information. Hats off to First Exposure for the great work and providing a platform of work that's evidence-based by people who are clinicians or experts in different aspects of this. It's quite risky because some of the social media information or dis and misinformation out there is very, very attractive. And in the past, I've had calls to rapidly fact check on behalf of various platforms. And some of the things look so, inaccurate, so informed, fictitious names with all sorts of qualifications behind their names and so on, from fictitious institutions that don't even exist, making points. So I'd say for every parent raising a child or someone planning a pregnancy, if we put that baby first, what will be the best steps to take in the best interest of the baby or the unborn child? That might help us be a bit more discerning. And how much of this is for us or for the baby? If it's putting us first and not the baby, perhaps we could reflect a bit on it and have safe private conversations if you need to. It's good to talk about weed and just let's keep learning. Even the experts are continuing to learn. One thing, as Suzanne said, because I can't waste this, but THC just loves fat. It loves fat. A large proportion of the brain is fat. A large proportion of our body tissue is fat. So the body has a capacity to store and slowly release. Think of it like squirrels putting away nuts. That's what THC, and then it just gradually releases it. So don't think just put it away once that it's done, and that's why we got these long timelines.
Deji, I just want to pick up on something you said, because I think there's this movement now. Well, we put the baby first for everything. As a mom or a parent, I want to put myself first, right? And so using cannabis here in a social group with other parents to help us relax once, here or there is taking care of myself. I'm just giving the flip side to that. So it was always about put the baby first. And there's a little bit of a movement right now, and there's positive aspects to that movement saying, I'm going to have that glass of wine. I'm going to have some cannabis at this party with other moms, and we're going to parent like this, and we're going to accept this. And Suzanne, I'm curious to see what you see and what you think about that sort of framework.
So I think there's a couple of things that make it a little bit more difficult when we're talking about lactation and the cannabis versus alcohol discussion. I also know that there's kind of, the provide breast milk regardless of how you feel, as long as you can still pick up the baby, you can feed the baby, that kind of thing. So there's, I think it happens both with alcohol and cannabis. Really, we know that alcohol is a small molecule. It doesn't concentrate in the breast milk the same way. There is a period of time where you can quote unquote pump and dump, or just wait longer to feed, and then baby won't have as much exposure to, or no exposure, depending on how long you wait, to the alcohol. We don't have that luxury with THC, and that's why it's a bit of a more nuanced conversation. I think providing the information that, we have evidence that it concentrates in breast milk. We have evidence that it can have very long timelines in the breast milk, even with a single exposure. Then patients can make an informed decision about, it may actually be really important for that lactating person to go and have that kind of social event and use cannabis. I think the part that makes me a bit concerned is not realizing that there may be an unintended consequence of using that breast milk for a day or a couple of days afterwards to the neonate. So is there another way that you could feed your baby that may be safer for you? And having that information, I think the assumption that it's totally fine is the part that I feel like is missing. So, it might be formula for some people. It might be, stored breast milk that they use during the period. I think what's missing is that kind of conversation about it.
That public health awareness around it.
It's not saying you can't do it, and that might be in your best interest. And I certainly want, the parenting, the child parenting dyad to be super healthy as well. And that might be going and having, a joint with your friends. But having the information about how that might impact your baby, I think, is equally important.
It's this balance that we have, and how do we play that balance and also do what's safest? And I actually think, Suzanne, what you said is it's the lack of information.
Exactly.
Or complete lack, actually, or misinformation, or Deji, as you said, disinformation. That's the missing piece, so that people can make informed decisions for what they think is best for themselves and their baby.
And that's the point I want to make there, in that if a person has been using cannabis or has used in the past particular cannabis products, and they know how they feel with its use as well. So we've got the sort of chemical bit, as in THC, whether in milk and so on, to the baby, but also behavioral bits. Now, let's say I'm a mum and or a parent, and I've used a joint or two or had edibles. If I know that I'm going to get all giggly and lose my coordination and get confused and sleep, then it's important I weigh that. So, okay, how would that affect my childcare if I was the only one providing care for the child without movements? Now, it could be that I've had the social event, I'm going to sleep it off after that night and resume support for the child the next day. And we must allow conversations about cannabis without judging.
Yeah.
I think, though, Deji, I have to say that I'm also cognizant, though, that sometimes it's difficult to kind of have that back and forth because we're coming from such different levels. As the healthcare professional, I think sometimes, like on social media, some of the people who are not healthcare professionals and who feel very passionately about cannabis use in parenting or, in breastfeeding, it can be difficult to have those conversations. And I hope that we move forward to a way where we both groups feel like they can have a discussion and dialogue, because I feel like there's a lot of concern amongst my peers who provide, prenatal care in terms of how do we have a good conversation about, well, this is actually what the evidence shows, and that's where I'm coming from, rather than kind of these like slick presentations that you mentioned that sound like super compelling, versus me kind of sitting here spouting off about studies. But how do we combat kind of some of the misinformation, and how do we have those conversations? I think it's really challenging.
Yeah. I think a good starting point is, doing what we're doing today, right?
Totally.
Obviously,
Yeah.
bringing up the questions that we know our patients and people in the community have, and being on social media and having that back and forth and that dialogue. So hopefully this podcast was helpful. I think this brings us to the end of today's episode. We've talked about so much. We could continue talking probably. but I hope people enjoyed listening about cannabis use in pregnancy and lactation. We covered a lot of ground and a lot of evidence, and thank you for opening up the discussion at the end about just the overall culture and how we can all do better together and open those lines of communication between us and patients and healthcare providers, and just so that we can talk about this and review the evidence so that people can make informed decisions that is best for their health and their baby. I want to say a huge thank you to Deji and Suzanne. Really, it has been so wonderful to have two experts in the field sharing their time and knowledge with me, with everyone who's listening, and just answering these really important and critical questions. For more resources on various topics, please visit firstexposure.ca. Thank you for listening and joining us today. If you found this conversation valuable, be sure to subscribe, share, and stay connected for future episodes. Thank you so much.
The First Exposure team acknowledges that our office is based on the traditional territories of the Anishinaabe, Wendat, Haudenosaunee, and the Mississaugas of the Credit, though the impact of our work can be felt across Turtle Island. First Exposure is committed to nourishing respectful relations with Indigenous communities whose knowledge of medicinal plants and environmental substances are a foundation of the pharmaceutical science on which First Exposure depends. This project has been made possible thanks to the vision and support of the Vora Miller Foundation and the participation of the Dalla Lana School of Public Health at the University of Toronto and Health Nexus.